Hello, everyone. Thank you for coming to my presentation over my DNP scholarly project. My name is Ashley Wilson, and my project is Effectiveness of the DASH Diet, Reducing Blood Pressure in African American Males. My DNP chair for this scholarly project was Dr. Rochelle Davis at Maryville University, and Dr. Kathleen Smith was my community chair. This project was submitted to the Catherine McCauley School of Nursing at Maryville University. To give an overview of the project, the problem found was that hypertension affects African American males at a greater rate as compared to other races and ethnicities. Dietary lifestyle changes are an important part in lowering and managing high blood pressure, so implementing a diet to help with blood pressure is vital for this population. The project looked at the DASH diet as a dietary intervention to lower the blood pressure of African American males who have been diagnosed with hypertension. The project was implemented at a free clinic that serves the target population. And the project was implemented over 5 weeks with a 1-month time frame allotted for follow-up visits. The results obtained did show a decrease in blood pressure for the one participant who implemented the DASH diet for 1 month, so it showed a positive effect in the intervention. So let me give you a little more detailed introduction of my project topic. My scholarly project looked at hypertension in African American males aged 35 to 65. So starting off with hypertension is a chronic condition with many different associated comorbidities, including obesity, diabetes, and high cholesterol. It is also a major precursor for cardiovascular disease, which can lead to heart attack and stroke. Hypertension is a chronic condition that affects individuals all around the world, and it is also a very common diagnosis here in the U.S. The American Heart Association has 4 tiers to define hypertension, which include elevated blood pressure, stage 1 hypertension, stage 2 hypertension, and then hypertensive crisis, which this last one requires immediate medical attention. Different ranges in blood pressure are associated with the different stages. Hypertension affects populations disproportionately, with African American males having the highest incidence rates. The 8th Joint National Committee, or JNC 8, suggests that healthy lifestyle changes such as diet, exercise, and weight control can potentially control an individual's hypertension. The dietary approach to stop hypertension, or DASH diet, is a diet that is recommended by the American Heart Association as one that can help lower blood pressure and has also been shown to improve overall health. This includes decreasing weight and BMI for individuals, improving their blood sugar, and lowering cholesterol, along with the improvement of blood pressure. So the DASH diet is one that encourages individuals to eat more fruits, vegetables, nuts, beans, and lean meats such as fish and chicken. And this is just a chart showing the different stages of blood pressure according to the American Heart Association. So it shows that elevated, stage 1, stage 2, and hypertensive crisis. The PICO question that directed my scholarly project was, in African American males aged 35 to 65 with hypertension, is the dietary approaches to stop hypertension, or DASH diet, effective in the improvement of blood pressure compared to no DASH diet? This question was also what directed the literature search for my review. The purpose of this quality improvement project was to determine if the implementation of the DASH diet for African American male patients with hypertension would improve their BMI and blood pressure readings post as compared to pre-intervention baseline values. The overall aim was to determine if compliance with the DASH diet would effectively lower and control high blood pressure and BMI, thus improving patient outcomes. While reading over the articles retained for possible use of my literature review, 4 major themes emerged: behavior, stress, socioeconomic status, and obesity. Behavior, stress, and socioeconomic status were more prevalent in articles regarding hypertension in African Americans, while obesity was seen often in studies regarding the DASH diet. Behavior was an aspect that could either be positive or negative, meaning it can either positively affect diet and blood pressure or it can negatively affect diet and blood pressure. Behavior, in the context of the studies that were used, can also include personal behaviors or those of family. Individuals who have a positive outlook on the diet have better chances of adhering to it. They also have a better chance of lowering and managing their blood pressure. Those who look at it negatively have the opposite effect, with decreasing chances of lowering or managing their blood pressure. Family influences behaviors by either being supportive of the individual's diet change or by pushing back against it. Family can also be a contributor when individuals with high blood pressure want to lower it so that they can be present for major life events like weddings and birthdays. Stress has many different layers and honestly can be linked to many of the major themes mentioned. Some of the more discussed forms of stress included communication, sleep, money, and availability of food. Communication can include how much information individuals are given regarding blood pressure and how to manage it, and also how the information is given to them, such as health literacy. Sleep can negatively affect blood pressure when individuals do not get the proper amount of sleep their body needs. And for some communities that are lower socioeconomic, this is a real issue as they may lose sleep due to noise, temperature, hunger, or pain. Money is a stressor as it is needed to get pretty much anything nowadays, including food and healthcare. And the availability of food can create a lot of stress for individuals who are lower socioeconomic status, as they may not be able to afford it, or it just may not be readily available in their community, if they're in a food desert. Socioeconomic status can include health literacy and food availability, as discussed in stress, which are a few places where the two themes can and do link. But lack of insurance is another part of socioeconomic status that came up. Insurance can play a big role in not only what healthcare they can obtain, but also the quality of healthcare individuals get. For some of those who do not have insurance, providers may be less likely to prescribe certain treatments, and they may be less likely to educate about hypertension as well, as compared to those individuals with insurance. This is a major burden, and again, this can also be linked to stress. Obesity is a major contributor to hypertension, along with other comorbidities that can in turn contribute to hypertension. It is a vicious cycle that continuously circles back around. There were two main concepts for my scholarly project: high blood pressure and manage. High blood pressure is a systolic blood pressure of 130 to 139, or a diastolic blood pressure of 80 to 89, which would be stage 1, or a systolic blood pressure of 140 or higher, or a diastolic blood pressure of 90 or higher, which would be stage 2. Individuals who meet either one of these criteria are considered to have hypertension. And then manage is to work upon or try to alter for a purpose. This would make the definition of management of high blood pressure working on an individual's hypertension to alter it for the purpose of obtaining a lower blood pressure. So looking at the theoretical framework for my project, the health promotion model by Nola Pinder was the theoretical framework that was used. This model focuses on activities that promote overall health and how individuals can obtain better health. Pinder states that the model helps to show that each person is an individual with actions and experiences that contribute to their personal health. This model helps promote healthy lifestyles, including diet and exercise, and it aligns with my scholarly project as it also promoted a healthy lifestyle. The DASH diet can help improve overall health and it can promote health. Now for methodology. The scholarly project utilized a retrospective chart review. So the project had participants who came into the clinic with high blood pressure. They had their pre-implementation vitals taken and recorded in their chart, and these included blood pressure, height, and weight, and height and weight were needed for BMI. The participants were then educated on the DASH diet, and it was added to their plan of care for them to implement. The participants then returned 1 month after implementing the diet for a follow-up visit on their blood pressure and for that 1 month follow-up visit on the DASH diet. At this follow-up visit, they had their vitals measured and recorded again in their chart, and again that included blood pressure, height, and weight. Looking at the design of the project, such as the setting and participants, it was implemented at a free clinic located in the South Central United States. This is a completely free clinic where individuals can come to not only get healthcare, but also free lab work and prescriptions if needed. The clinic is ran by volunteers, from the providers to the nurses to medical and nursing students and non-medical individuals who help at the front desk. The participants were part of a specific target population, which is African American males aged 35 to 65 who have a diagnosis of hypertension. So, inclusion criteria for the project included African American males, 35 to 65 years old, a documented diagnosis of hypertension, documentation of 1 month post-implementation follow-up visit, DASH diet intervention implemented, baseline systolic and diastolic blood pressure, and body mass index. Follow-up systolic and diastolic blood pressure and BMI. And then exclusion criteria included not African American, not male, not 35 to 65 years old, no diagnosis of hypertension, patient was not seen at the clinic during the project's time frame, or they did not come back for their follow-up 1 month visit, and a total of 41 charts were needed for power to be statistically obtained. Recruitment for this project was not necessary as it was a retrospective chart review. The intervention implementation for the project ran for 5 weeks, and then once the 5 weeks was over, I waited 1 month to allow for follow-up visits, and then after that 1 month period, I then started collecting data. The data needed for the project included baseline measurements for blood pressure and BMI, and 1 month post-implementation measurements for blood pressure and BMI. So BMI is determined by a person's height and weight, which is why blood pressure, height, and weight measurements were needed in the participants' charts. A data collection sheet was created to help keep track of the data and to help organize it. The data collection sheet included the chart number, baseline blood pressure, and BMI, if the participant received a DASH diet handout, if the participant came back 1 month after implementing the DASH diet, and the subsequent blood pressure and BMI measurements. To obtain power in the project, 41 charts were needed. The handout that providers gave participants was provided by the National Institutes of Health, and the National Institutes of Health provides handouts on its website free of charge for anyone to use. The handout that was utilized helped go over the basic aspects of the DASH diet and different ways to integrate it into one's daily routine. Protecting the participants and any human subject for that matter was of utmost importance. The main potential risk is breach of confidentiality. This risk was addressed in the project and procedures were put in place to help reduce and mitigate it. The data collection sheet did not include any participant identifiers, which did help reduce risk. The charts at the clinic were paper charts, and they were kept at the clinic at all times. They were only pulled from the filing cabinet for data collection and then refiled once reviewed. Only information needed for the project was obtained, and names of the patients meeting criteria were kept on a list with the clinic director, and then they were destroyed once the data collection ended. The variables or data sets were dependent, meaning the variables that were variables that were expected to change due to the implementation of the diet, and I needed to have 2 measurements each for them to be complete. The first measurement was pre-diet implementation or baseline measurement, and the second was post-implementation of the DASH diet. These measurements were used to determine if the DASH diet helped the population in lowering and managing their hypertension. A paired t-test was the ideal statistical analysis for the project. The project originally anticipated to have 45 completed charts, as 41 were needed to obtain statistical significance. Once the project ended and the data collection started, it was determined that there were a total of 8 participants in the study and 1 completed chart. This 1 completed chart was used for data analysis, and it was the only one to meet all criteria needed. A paired t-test was attempted but was deemed invalid due to the small size and data obtained. Therefore, Excel was used for analytics and descriptive statistics were used to analyze the data. Again, this was due to only 1 completed chart that was obtained. For the results of the project, since there were 8 charts obtained and only 1 of those charts were complete with post-implementation variables, again, only 1 chart was used for the analytics. And since only 1 chart was used, of the 41 charts that were needed to obtain statistical significance, descriptive statistics were used to analyze it. The systolic blood pressure decreased from 183 to 144, and the diastolic blood pressure decreased from 104 to 92. The BMI for this participant increased 1 point after implementing the DASH diet for 1 month. As I stated previously, significance was not obtained. This was due to the less than anticipated obtained data. The data that was collected did, however, show a decrease in blood pressure after 1 month of implementation of the DASH diet. So I do want to talk about the lower than expected amount of charts for the project. COVID-19 played a large role in this. Since the clinic is ran by volunteers, COVID caused a decrease in volunteers due to sickness. When there were not enough volunteers, the clinic had no option but to not open. During the project timeframe, the clinic was closed every other week due to the lack of the volunteers. This not only created a decrease in the number of participants, but it also created issues with the 1 month follow-up for participants, as it kind of threw that off. Okay, so implementations for nursing practice. This was positive because the project showed that the DASH diet does work and that it can be used by clinicians everywhere. The clinic that implemented the project, they actually kept the DASH diet intervention and they implemented it into a policy. It is now being added to the care plans of all individuals who come to the clinic and have a diagnosis of hypertension. The DASH diet is a great overall diet to help with health, and decreasing blood pressure will also help to decrease the risk of comorbidities for many individuals and therefore decrease the burden on the healthcare system that hypertension can cause. So implications for future research. The project was created and implemented in a way that other researchers can duplicate it and complete their own study of it. This study had a specific target population, which leaves expanding the inclusion criteria as room for future research. This project also had a short implementation period. It was only 5 weeks long. So future research could absolutely extend the implementation period, and that would allow for more data and potentially it could create statistical significance. In conclusion, hypertension is a chronic condition that is common throughout the world. It can come with comorbidities that can also contribute themselves to increased blood pressure, including obesity, diabetes, and increased cholesterol and cardiovascular disease. The DASH diet is one that can not only help lower and manage high blood pressure, but it can also help increase an individual's health when it is adhered to. The Scholarly DNP project was implemented, and data obtained showed the DASH diet did have positive effects, lowering blood pressure after 1 month of implementation. The DASH diet is one that can be used by clinicians everywhere, adding the diet to care plans of patients who have a diagnosis of hypertension. This project focused on African American males aged 35 to 65 with hypertension and resulted in positive effects on lowering and managing their blood pressure. And so I do want to ask if there's any questions, absolutely feel free to reach out to me. Again, my name is Ashley Wilson, and I have my email address here on this screen. It is awilson13@live.maryville.edu. I would absolutely love to talk to you. And thank you everyone for coming to my presentation. These are my references.